which is the most common region in rheumatic heart disease. It is nothing but the severity of rheumatic fever. Mitral stenosis means it is narrowing of the mitral valve opening, which is the most common region. Followed by the next common valve involved is aortic valve, but mitral valve is the most commonly involved in rheumatic heart disease. So rheumatic heart disease is nothing but the permanent heart valve damage as a result of one or more attacks of acute rheumatic fever. The normal area of mitral valve is 4 to 6 cm square. In mitral stenosis, reduce up to less than 1 cm square, then it is called as critical mitral stenosis. So the basic pathology is that there is thickening and immobility of the mitral valve leaflet, the fibrosis at the annulus, and commissural fusion. So all these basic pathology lead to narrowing of the mitral valve opening. So if the mitral valve opening is narrowed, that means there is obstruction to the flow of blood from left atria to left ventricle during diastole. The blood from atria to ventricle is not able to come. That is called as diastolic in diastolic phase. It is characterized by obstruction to the ventricular inflow at the level of mitral valve due to structural abnormality at the mitral valve apparatus. See, this is the normal your mitral valve. It is embrus is nothing but it is the fibrous ring. Commissure is nothing but it is the part where the two structures join. Two structures join means mitral valve consists of two leaflets, anterior leaflet and posterior leaflet. So where the two leaflets they join to each other, that is the commissural part. This is the annulus. Then two leaflets. This is chordae tendineae and this is the papillary muscle. The function of chordae tendineae is to attach the leaflets to the papillary muscle. So this is the whole your mitral valve apparatus. So there is thickening, there is fibrosis, there is stiffness of the leaflets, there is fibrous tissue laid down at the annulus, there is commissural fusion, and all this pathology leads to narrowing of the mitral valve opening. The most common cause of mitral stenosis is rheumatic heart disease, next is congenital, and then intrauterine tumor, but these are the rare causes. Mitral stenosis is almost always rheumatic in origin. Fibrosis and calcification, fusion of the cusp and subvalvular apparatus. Progressive fibrosis, calcification, fusion of the cusp or subvalvular apparatus, that is leads to narrowing of the mitral valve area. Back pressure effect and problem with the forward circulation. So these are the hemodynamic changes or hemodynamic disturbances that occur due to mitral valve narrowing. So if mitral valve opening is narrowed, there is mitral stenosis. What are the effects on the heart? What are the hemodynamic changes that are occurring in the heart? So there is problem with backward circulation, problem with forward circulation. Forward circulation means stroke volume and cardiac output is occurring, and backward circulation means there is increasing pressure in backward direction. Left atria to pulmonary vein to capillary, capillary to pulmonary artery to right-sided heart, like that. So they ultimately it leads to pulmonary hypertension, right-sided heart failure. So right-sided heart failure, two classical signs of right-sided heart failure: increased jugular venous pressure, enlarged liver, that is congestive hepatomegaly, and edema over the lower limb. Increased JVP, congestive hepatomegaly, swelling over the lower limb. These are the signs of right-sided heart failure. So back pressure effect ultimately lead to right-sided heart failure. And forward circulation problem leads to decreased stroke volume, decreased cardiac output, so that the body's tissue will not get proper nutrition, proper blood supply, and all tissues are affected, particularly GIT, kidney, muscles, etc. And the symptoms according to that. That is the basic pathology or the hemodynamic disturbances that are occurring because of mitral valve narrowing. That is the pathophysiology. Clinical features. The most common complaint of patient is because of backward circulation, because of forward circulation. When cardiac output is decreased, stroke volume is decreased, there is decreased blood supply to tissues of the body that leads to fatigue, anorexia, nausea, polyuria, etc. And because of back pressure effect, increased pulmonary venous pressure, increased pulmonary capillary pressure, increased pulmonary artery pressure, this leads to pulmonary edema. If pressure in the capillary, pressure in the artery, pressure in the vein increase, that means if there is increase in hydrostatic pressure in the vein, if hydrostatic pressure in the vein increase, there occurs exudation of fluid coming out from the muscular compartment to the interstitial compartment. So there occurs interstitial edema. Fluid comes in interstitial spaces initially and later on in the alveolar spaces. So there is interstitial edema in the lung, and later on there is alveolar edema in the lung, that is called as pulmonary edema. So back pressure effect leads to pulmonary edema. Pulmonary edema is nothing but collection of fluid in interstitial spaces of lung and in the alveolar, and that hampers the oxygenation of blood, that leads to hypoxia, and because of this hypoxia, patient complains of breathlessness. Breathlessness is mainly because of problem with backward circulation because of pulmonary venous congestion or pulmonary edema. The most common complaint is breathlessness, but patient remain asymptomatic until the stenosis is critical, until your heart is able to compensate the hemodynamic changes. The patient will remain asymptomatic until your heart is able to adjust with the hemodynamic disturbances. But once your heart fails to adjust these hemodynamic changes or hemodynamic disturbances, then patient becomes symptomatic. This patient becomes symptomatic when stenosis is less than 2 centimeters square. The most common complaint is breathlessness, then fatigue, edema. These are the signs of heart failure. Palpitation. Palpitation is nothing but increased heart rate. Patient is aware of our own heartbeat, and this is because of cardiac arrhythmia. These patients are more prone for cardiac arrhythmia. Means your heart producing extra beats, extra echo beats. These extra beats lead to increase in heart rate, and that is called cardiac arrhythmia. Your rhythm of the heart will not be regular. The heart rhythm becomes irregular because of production of extra beats. The heart rate is irregular and there is increase in heart rate, and that leads to patient to complain palpitation. Hemolysis, this is because of pulmonary congestion, pulmonary edema, that is blood in the sputum, pinkish foggy sputum, patient will to complain. Then cough is again because of pulmonary congestion. So cough, hemolysis, breathlessness, these are mainly because of pulmonary congestion and pulmonary edema. Then non-specific chest pain and thromboembolic complication. These patients are more prone for thromboembolic complication. How we will see later on. So these thromboembolic complications mainly because of the pressure in the left atria or the blood volume in the left atria go on increasing because there is obstruction to the flow of blood from left atria to left ventricle. That means blood go on stagnating in the left atria. There is increased blood volume in left atria, that will increase pressure in the left atria, and this leads to enlargement of the left atrial chamber. The left atrial chamber get dilated, and because of dilatation, because of stagnation of the blood for a long time in the left atria, then it leads to formation of a clot. Because of stagnation and because of enlargement of chamber, it leads to formation of clot. So this clot formation, that means left atrial thrombus, is there. And when the patient land in arrhythmia, when patient land in arrhythmia means producing extra beats, extra ectopics, extra beats, patient land in arrhythmia. That means the most common arrhythmia is atrial fibrillation. Most common arrhythmia is atrial fibrillation. Atrial fibrillation means formation of extra beats from the atria. There is formation of some ectopic foci, formation of some foci in the left atria, and this foci means cardiac tissue producing extra beats rather than conduction system. The beats mainly produced by conduction system, but the extra beats are produced by cardiac tissues because of formation of ectopic foci. And when ectopic foci are in the atria, it leads to atrial fibrillation. Atrial fibrillation, atrial flutter is the most common cardiac arrhythmia that occur in microstasis. And when patient land in atrial fibrillation or atrial flutter, means in cardiac arrhythmia, there occurs formation of small emboli or small emboli detached from this thrombus, which is from the left atria. Small emboli detached from the thrombus, they circulate in the blood and they lodge in any organ in your body. That is thromboembolic complication. The small emboli detached from the thrombus circulate in the blood and they can block any blood vessel in your body. They can block any blood vessel of any artery in the body. But the most common embolic complication is they can occlude your cerebral blood vessels. Emboli usually occlude your cerebral blood vessels. That is the most common embolic complication. And when they occlude your blood vessels of brain, when they occlude the blood vessels of brain, that means there occurs damage to your brain, ischemia of your brain. That is called as infarct of the brain tissue. It is called infarct of brain tissue, or in short, it is called cerebrovascular accident (CVA). In short, it is called cerebrovascular accident (CVA). Is nothing but it is the infarct of brain tissue because of occlusion of blood vessels of brain as a result of thromboembolic complication. And that results in patient may sometimes present with paralysis. And that results that patient presented with paralysis. Either one-sided, that is called as hemiplegia. When it involves single limb, it is called monoplegia. When it involves half side of the body, means upper limb, lower limb, it is called hemiplegia. Hemiplegia means weakness of upper limb, lower limb on one side. That is hemiplegia. Monoplegia means weakness in only single limb, either upper limb or lower limb. That is called monoplegia. Paraplegia means it is the weakness in both lower limb. Then it is called paraplegia. When weakness occurs in all four limbs, upper limb as well as lower limb, then it is called quadriplegia. So most commonly patient presented with hemiplegia. That is the thromboembolic complication. Most common stroke, occluding cerebral blood vessels, infarct of brain tissue, and patient presented with hemiplegia. Stroke is the most common thromboembolic complication. Thromboembolic complication occurs because of formation of clot in the left atria, and when patient land in arrhythmia, there occurs detachment of small emboli from this thrombus. They circulate in the blood and they can occlude any blood vessel in your body. But the most common blood vessel in the body is cerebral blood vessel. That is thromboembolic complications. So this is about clinical features, signs and symptoms. So patient presentation is like that. Clinical signs, general and system examination. We discussed yesterday, general examination, the positive signs, tachycardia because of cardiac arrhythmia, mitral fishes, see like this is the mitral fishes, it is nothing but the erythematous rash over the nose and cheek, this is called as mitral fishes. Low or normal blood pressure can fall if mitral stenosis is very, very critical. Edema, increase jugular venous pressure. These are the positive signs on general examination. On systemic examination, that is examination of cardiovascular system, you get the presence of murmur, that is diastolic murmur. In inspection, you are to see the position of apex impulse. In palpation, you are to confirm the position of apex impulse and the palpable murmur, that is thrill. So presence of thrill, presence of parasternal here on palpation. Then in auscultation, you have to auscultate the heart sounds. Whether there are two heart sounds, that is S1, S2, that is normal. But in presence of extra heart sound, S3, S4, then it is called as gallop rhythm and it is a sign of heart failure. Presence of S3 or S4. So presence of S3 always suggests heart failure, which is called as gallop rhythm. Then presence of murmur. Presence of murmur. This murmur is nothing but it is the harsh rumbling sound. Now what is murmur? Murmur is harsh rumbling sound which is produced in the heart because of increased turbulence in the blood flow. Because of increased turbulence in the blood. So this turbulence in the blood flow occurs because your blood flows through the narrow orifice. Your blood flows through the narrow orifice. The diameter is small. Blood has to pass through the narrow orifice, and this causes increased turbulence in the flow of blood. And whenever there is increased turbulence in the flow of blood, that produces a sound of harsh rumbling, which is called as murmur. So this harsh rumbling sound or the murmur is produced when blood coming from atria to ventricle. Whenever blood coming from atria to ventricle, blood has to pass through the narrow orifice. At that time, it produces this harsh rumbling sound, that is the murmur, and it is the diastolic phase of your heart. It is the diastolic phase of your heart, so it produces diastolic murmur. So in mitral stenosis, there is presence of diastolic murmur in auscultation. Opposite to that, we will discuss in MR, that is in mitral regurgitation. So you should know why murmurs are produced. You should know why murmurs are produced. There are two mechanisms of producing murmur. One, if blood has to pass through the narrow orifice, it will produce turbulence in the flow. Or if orifice is normal, blood, an increased volume of blood has to pass. Means more than normal volume has to pass through the normal orifice. So that also produces turbulence in the flow. That also produces turbulence in the flow, and that also produces harsh rumbling sound, that is murmur. These are the two mechanisms of producing murmur in valvular region or in the heart, and that is the murmur. So, examination of cardiovascular system, examination of respiratory system, you get crepitations at the basis of lung, which is due to pulmonary edema. This fluid in the interstitial spaces, fluid in the alveoli, that produce crepitations, crackling sounds on auscultation. Abdominal examination, you get enlarged painful liver, that is congestive hepatoma. Investigations, ECG, electrocardiogram, X-ray chest. In X-ray chest, you get the heart like this. Enlargement of left atria. There is enlargement of left atria, which causes the straightening of the left quarter of heart. The left quarter of heart becomes straight, which is because of enlargement of left atria. This is the right border of heart. This is the left border of heart. This is the right border. Right border is mainly constituted by right atria. So this is the part of right atria. And this second shadow, there are two shadows. This is one shadow of right atria. This is the second shadow. This second shadow is of left atria. Enlargement of left atria causes the left atria to come on right side. This enlargement causes the left atria to come on right side also. So this is the enlarged left atria. This is right atria. This is a double shadow. This is double density sign, also called as double density sign or double shadow in hypostasis. And here there occurs straightening of the left border of heart because of enlargement of left. So from X-ray chest, you can diagnose that there is something wrong with your cardiac shadow. Something wrong with your cardiac shadow, and you have to rule out some pathology. So ECG, X-ray chest, 2D echocardiography is diagnostic. You can view the mitral bone and the damage to the mitral bone. You can measure the mitral bone area. You can see the damage to the leaflets, everything. So mitral stenosis is diagnosed from 2D echocardiography, and it is the diagnosis with color Doppler. This is to see the flow of blood and cardiac catheterization. These are the investigations. ECG, X-ray, 2D echo with color Doppler. These are the basic investigations for diagnosis of mitral stenosis. Now the management. The patient with minor symptom can be treated medically, but medical management has very limited role in any valvular heart disease. Medical management has a minimal role in any valvular heart disease because with medicine you cannot correct the valvular defect. With medicine you cannot correct the valvular defect that occurs. The defect that occurs you have to always correct with surgical management. So, valvular defect is always repaired by means of surgery or surgical management is the definitive management in any valvular heart disease. Surgical management is the definitive management. Medical management has limited role. Medical management includes just management of complications. Just management of complication. But with medicine you cannot correct the defect or the damage whatever occurred to the bone. For that, only surgery is required, and surgery is always definitive. So, what surgery you have to do? So in microstenosis, you know there is narrowing of the mitral valve opening. Now you have to open up. Means you have to increase the lumen of the mitral valve opening. You have to make it bigger. You have to make it bigger. That means you have to make the mitral valve opening larger. So that is called as mitral valvotomy. So with the help of balloon, if your mitral valve is not calcified, is not too rigid, then with the help of balloon you can dilate. With the help of balloon you can dilate the mitral valve opening. That is called as balloon mitral valvotomy, which is called balloon mitral valvotomy to increase the diameter of mitral valve opening with the help of balloon if it is not calcified, and to break down the fibrous tissue at the annulus. To break down the fibrous tissue at the annulus. So, balloon mitral valvotomy. If your wall is very stiff, thick, calcified, you cannot dilate with balloon, then you have to replace the wall with the prosthetic wall, that is called mitral wall replacement. That is called mitral wall replacement. So, you have to replace the mitral wall with prosthetic wall, which is called as mitral wall replacement. So, balloon valvotomy or mitral wall replacement, that is the surgical management. What medical management include? As we discussed, medical management is nothing but it is the management of complications of microstenosis. Most common complication of microstenosis, as we discussed, is the heart failure. Cardiac failure, patient ultimately lead to cardiac failure, and the basic problem with heart failure is pulmonary congestion, pulmonary edema, flooding interstitial spaces of lung, flooding the alveolar part of lung, and which hampers your oxygenation of blood and leads to hypoxia. Now, how to remove that fluid from the lung? Your basic aim is to remove that fluid from the lung so that the oxygenation will be better. Patient should not be hypoxic. The oxygenation of blood should be better. So you have to remove the fluid from the lung. Now how to remove that fluid from the lung? So the drug use is diuretics. The role of diuretics is to remove excess of fluid from your body by increasing urine output. That is the role of diuretics. And the most common diuretic use is furosemide. Next is spironolactone. So these are the two most common diuretics. One is furosemide, second is spironolactone. So with the help of diuretics, you can remove that excess of fluid from the body, excess of fluid from the lung, excess of fluid from your lower limb. That is when there is lower limb edema, when patient is with ascites. Ascites means fluid in the vertebral cavity. So whenever there is excess of fluid, whenever there is excess of fluid in your body, in the form of either pulmonary edema, in the form of swelling over the lower limb, in the form of ascites, anything. That is the third space loss, means fluid coming in the interstitial spaces. So this excess of fluid in the body is always removed with the help of diuretics. The most common diuretics is furosemide and spironolactone. So management of heart failure into use of diuretics to remove excess of fluid, so that patient get relief, the excess of fluid from the lung is removed, and there will be better oxygenation of blood, and patient get symptomatic relief from breathlessness. Patient gets symptomatic relief from breathlessness. Now, second complication is cardiac arrhythmia. The second complication is arrhythmia. As we discussed, atrial fibrillation is the most common arrhythmia in microstenosis. Atrial fibrillation means extra beats are produced from the atrial tissue. As atrial fibrillation, that leads to irregular heart rate, that leads to irregular heart rate and increasing heart rate. Your heart rate can be up to 150, 200 or up to 300. So your aim in cardiac arrhythmia is to control heart rate. Your aim is to control heart rate. Now, how to control heart rate? There are two main drugs to control heart rate. One is beta blocker, second is calcium channel blocker. So with the help of beta blocker and with the help of calcium channel blocker, you can control the heart rate. So the role of beta blocker, like metoprolol, role of calcium channel blocker, like diltiazem, verapamil, and digoxin. Digoxin is also used to control heart rate. Digoxin, calcium channel blocker, beta blocker to control the heart rate. Now, as we discussed, third complication, that is embolic complication. There is formation of clot, and there are thromboembolic complications in microstenosis. Now, to avoid this thromboembolic complication, on 2D echo you can see the presence of clot in the left atria. On 2D echo you can see the presence of clot in left atria. If there is a presence of clot in left atria, that is can be seen on 2D echo, then You are to prevent the embolic complications. Now, how to prevent embolic complications? For that, you have to do anticoagulants. For that, you have to do anticoagulants. So, anticoagulants like heparin and warfarin. And that you have to do lifelong. This anticoagulant therapy you have to do lifelong. Initially, heparin, later on, warfarin. So, patient has to take warfarin lifelong to prevent embolic complication if there is a thrombus in the area. So, that is the third most commonly used drug is anticoagulant. So, treatment of heart failure with diuretics to control heart rate with beta blocker, calcium channel blocker, antioxidant to prevent embolic complication, anticoagulants. Now, next common complication is infective endocarditis, which we have discussed later on in detail. Infective endocarditis is nothing but it is the infection of your cardiac walls by bacteria. So, as your cardiac walls are damaged, the surrounding endocardium is damaged. So, this damaged area is very, very prone for infection. This damaged area of the heart is very prone for bacterial infection. That is called infective endocarditis. Now, already your heart is damaged, your cardiac walls are damaged, so they are more prone for bacterial infection, that is infective endocarditis. Now, the prevention of infective endocarditis is whenever you are doing any procedure, any intervention, which can lead to septicemia, which can lead to bacteremia, and so that the bacteria can reach up to your heart. So, before doing any procedure, before doing any intervention, to avoid this bacteremia or to avoid this septicemia to occur, we have to do antibiotic prophylaxis. So, prevention of infective endocarditis before any procedure with antibiotic. So, we have to do antibiotic cover before procedure, during procedure, after procedure to prevent occurring this complication. So, your aim in medical management is diuretics, beta blocker, calcium channel blocker, deoxy, anticoagulant, prevention of infective endocarditis. And if blood pressure is low, if patient blood pressure is low, you cannot use vasopressors. There is very minimal role of vasopressors. There is no minimal role of vasopressor in blood pressure. So, because the definitive treatment is surgical treatment. Even though you use vasopressors, there is less blood volume in the left ventricle, or there is no blood volume in the left ventricle. So, how to increase the stroke volume or how to increase the cardiac output? So, only using vasopressor you cannot increase cardiac output, you cannot increase stroke volume of the patient. For that, you have to always do surgery. That is what I call minimum role of vasopressor. That is the medical management of the patient. Complications, as we discussed, heart failure, mostly the right-sided heart failure, atrial fibrillation, thromboembolic complication, and inflammatory. So this is all about mitral stenosis.